Up next, we're going to hear from Dr. Christine Matarese from Mayo Clinic on sleep disruptions in Dravet syndrome. But similar to the behavior talk, we're first going to bring up DSF ambassador and caregiver Amy Lopez to share a little bit about her lived experience with her son Isaiah and sleep.
Oh, they weren't lying about these lights. Can't see anything. Well, it's good. No one's here, so. My name's Amy Lopez. I live in the Boston area, and my son Isaiah is 13 years old. When he was very young, he would sleep for a few hours, and then he would party for 4 hours, and someone had to get up and party with him, and that someone was usually me. So I would try to keep him entertained as much as possible, and then he would eventually crash and go back to sleep. At this point, he was still sleeping in his crib. And then things began to change a little bit, where if I would go to bed with him and sleep with him, he'd fall asleep and tend to sleep a little bit longer. So we would cram into his little IKEA bunk bed thing, and I would wait till he'd fall asleep, and shortly after I would be able to crawl into my bed. And like Jen mentioned early in the program, we just had like a regular baby monitor at this point because Dravet and epilepsy wasn't, well, we knew he'd had seizures, but we didn't have a Dravet diagnosis and didn't know much about SUDEP and weren't really aware of all the potential things that could happen. After that, we were gifted with an MFIT monitor, and we transitioned him from a crib to a toddler bed, and this is when we started with the MFIT monitor. The MFIT monitor for us is perfect because most of my son's nocturnal seizures were tonic-clonics, and the MFIT monitor would pick this up. The MFIT monitor started to give my husband and I some PTSD, or I don't even know if you call it the P anymore, just any kind of noise, or I think I'm too close because I keep hearing any kind of noise that we would hear, or sirens, or any beeping would kind of trigger us. So we'd hear it, and again, we'd look in the camera, and it was always accurate for his seizures, and we'd run in there. About 4 years ago, we moved into a new home, and my son started having not full body tonic-clonics, but the only thing that would let me know he was seizing is his eyes would vibrate. So he would get a little stiff. I could feel him kind of turning towards me, but I'd have to open his eyelids, and I would just see the vibration. So of course, the MFIT monitor is not going to pick up on that. So that's when we decided to co-sleep for the whole night. My son is 13, as I mentioned, and he still wakes up probably 3 to 4 times a week and wants to eat. So I will run downstairs and make him waffles with peanut butter, and yep, he eats them right in bed, but it's the only way I can keep sleeping. So he'll eat those and then go right back to sleep. Co-sleeping for us is probably the best thing that we've done for our family, not just for the safety issues, but I go to these conferences and I'm always like, yes, I'm finally going to get a bed to myself. I'm going to sleep great. And I actually do not sleep good at all because I'm so used to having him with me. But I can, I guess it's a parent instinct. I can feel him as he's seizing start to turn into me and get stiff, and I automatically wake up, and we're right there to care for him. What we're going to do when he's really, really big and takes over the bed, I'm not sure, but as we all know, we just take it one day at a time, and we'll figure that obstacle out when we get to it. But so far, that's been the best thing for us, is just having him right there with us. I guess that's all I have to share. So if there's any questions? No? Okay, great. It was so nice to see all of you for the first time, to meet some of you and see all of you again for second, third. And again, we'd like to thank everyone that's here. So thanks.
Hello. I'm just going to try something with this mic. Can you hear me? Perfect. So thank you for coming back after the break. My name's Matarese. I'm a sleep medicine physician and a pediatric neurologist at Mayo Clinic. And I was asked to talk about sleep disruptions in Dravet syndrome, and I appreciate the opportunity to talk at your conference. So I don't have any financial disclosures, but there are no FDA-approved medications for insomnia in the pediatric population. So every medication that I will be mentioning, including melatonin, is off-label. In terms of an overview, I'll talk about the different types of sleep concerns in Dravet syndrome. And I'll also point out a few things that I thought were interesting in the literature. I'll talk a little bit about obstructive sleep apnea in patients with epilepsy, because it's more common in patients in epilepsy, particularly in those with refractory epilepsy. And then I'll mention a little bit about what is involved in an overnight sleep study and another type of test that we use in sleep medicine called actigraphy. I'll talk about some of the OSA treatments in the pediatric population, and then insomnia. Just as a way to start, this was based on caregivers' experiences in Dravet syndrome specifically with the source of stress in their household. And so 24 parents of patients with Dravet syndrome participated. So no surprise, seizures were the greatest source of stress. However, out of those 24 parent-children pairs that were involved, 22 reported sleep problems. So of those sleep problems, they weren't only nocturnal seizures, because obviously nocturnal seizures disrupt your sleep, but there was a large percentage of trouble falling asleep, trouble staying asleep, and almost half were on a medication to try to help with sleep. So this was also a parent survey done by the Dravet Syndrome Foundation. And I forgot to mention, the first study, the average age of the child was 10 years. So in this one, the average age of the child was 7.5. And 53% reported nighttime seizures, but 76% reported nocturnal awakenings that were not in the setting of a seizure. And I just wanted to highlight some of the findings because I think it's a nice overview of what's representative in this population. So I know in sleep medicine, you hear a lot about sleep hygiene, a consistent bedtime, a consistent rise time. So that's obviously easier said than done. But in the patients with Dravet syndrome, about 72% did have a consistent bedtime, 50% had a consistent rise time, 70% fell asleep in less than 30 minutes, which is considered a normal sleep onset latency. But it took over an hour for about 11% to fall asleep. 72% had restless sleep, and then 67% reported symptoms of sleep-disordered breathing, such as snoring or open-mouth breathing or bruxism, grinding your teeth. Yet only 32% had an actual diagnosed sleep disorder. And 67% took a prescription medication to assist with sleep, and the vast majority of those medications were melatonin. So this is a study that was performed by some of my colleagues at Mayo Clinic back in 2014, where they looked at sleep abnormalities based on an overnight sleep study, or polysomnogram, which I'll call PSG, in 6 children that had genetically confirmed Dravet syndrome. So mean age was 6 years. There were more girls than boys, and these patients had been seen by sleep medicine and had an overnight sleep study. The reasons they were sent to sleep medicine in the first place were daytime sleepiness or daytime behavioral symptoms that could suggest fragmented sleep, such as hyperactivity or inattention or behavioral concerns, as well as frequent nocturnal awakenings So when you look at an overnight sleep study, there's some typical parameters that you look at. So those were looked at. For example, sleep efficiency, what percentage of the time you're in bed are you actually asleep? Sleep architecture, meaning does your brain go in and out of the sleep stages in the normal percentage of the night? But they also looked at something that we don't normally look at when we're looking at a PSG, something on the EEG called cyclic alternating pattern. That's kind of considered micro-architecture as opposed to macro-architecture of your sleep. And it's an EEG pattern where you alternate like high amplitude frequencies with lower, similar to what you see in neonates, preterm and term babies. And it basically indicates more unstable sleep, and the thought is it reflects brain immaturity, because with age, you outgrow that pattern. So what they found was between the children with Dravet syndrome and the children without it, there were not any abnormalities in the typical macro structure of sleep. So the typical sleep study parameters that we look at were the same in both groups. However, this cyclic alternating pattern, the percentage of that made up non-REM sleep was higher in the Dravet syndrome kids than those without. They said the typical proportion of non-REM sleep spent in it is about 30-ish%, but in the children with Dravet syndrome, it was about 50%. So there's a lot of theories about why there's such a prevalence of sleep disturbances in Dravet syndrome. And as you are well aware, mutations in the SCN1A gene are responsible for the majority of the Dravet syndrome cases. And as was already mentioned today, that particular gene codes for a particular transmembrane protein, NaV1.1, which is a voltage-gated sodium channel. So there's a mouse model with this same abnormality, and that transmembrane protein was expressed in regions of the brain that were important for both sleep regulation and for seizure generation. And the mutant mice with that mutation showed increased wakefulness and decreased non-REM sleep. So this is an article that basically is an example of that, where they had a mouse model of this loss of function mutation in the SCN1A gene that encodes for that protein. And the mice with that mutation developed seizures in their first month of life. This is another article that also mentions the same topic, with an SCN1 mutation that causes GEFS plus, or genetic epilepsy with febrile seizures plus. So not Dravet syndrome, but another epilepsy syndrome with the same gene. And they also used a mouse model, and they saw that these regions were expressed in the brain in areas that were involved in sleep regulation. So I can't say this without laughing, because I'm just picturing the mice undergoing an EEG. So the mice underwent an EEG before and after 6 hours of sleep deprivation. And at baseline, before the sleep deprivation, they found increased wakefulness and reduced both non-REM and REM sleep in the mutant mice. But during and after sleep deprivation, the EEGs were similar. But then they did staining of the brain regions, and they found regions in the brain that expressed that protein. Same thing. They were involved in regions of seizure generation and sleep regulation. So the authors of this article felt that patients with the SCN1A mutations may experience alterations in their sleep based on the expression of this gene, or the poorly encoded protein that this gene is responsible for, because of the brain regions that it's expressed in, because those areas not only involve seizure generation, but also sleep regulation. So I wanted to jump a little bit about reasons to consider seeing sleep medicine. So children with epilepsy have an increased risk of sleep-disordered breathing. So sleep-disordered breathing is the umbrella term for obstructive sleep apnea or central sleep apnea or hypoventilation, meaning you're basically retaining carbon dioxide overnight. You're not exhaling it fully. And children who have abnormal muscle tone, hypotonia, or low muscle tone also have an increased risk of sleep-disordered breathing, basically because the muscles surrounding your airway that normally keep it open decrease in tone in sleep. So if you have decreased tone at baseline, when you fall asleep, you're going to have even more decreased tone. So some children with refractory epilepsy and delays can also have abnormalities in muscle tone. So major symptoms of obstructive sleep apnea, or the typical symptoms, are snoring, but not all snoring kind of has the same weight. So children who snore just when they're ill or only when they're on their back, less of a suspicion for sleep-disordered breathing. But if your child is snoring on a nightly basis in any sleep position, heard through the bedroom door, those types of snoring symptoms are more suspicious for an underlying sleep-related breathing disorder. Also, I think everyone thinks of sleep apnea, or at least I did, symptoms during the day where people can't keep their eyes open, they're falling asleep, they're dozing off, drowsy driving. That's true in adults. But in the pediatric population, it's actually, you see less symptoms at night and you see more symptoms during the day, meaning behavioral, attention, emotional dysregulation, similar to ADHD symptoms from fragmented sleep. So just a little blurb about obstructive sleep apnea. It's a sleep-related breathing disorder, so it's not a problem when you're awake. But when you're awake, your muscle tone is good. Your upper airway is supported by muscles around it that help keep it open. But then when you fall asleep, your muscle tone decreases, so your upper airway gets smaller in diameter. So then if you have low muscle tone, a large tongue base, big tonsils, big adenoids, something else taking up space in that tube, there's less room for air to flow. So you get less air to your lungs, and then you get less oxygen to your bloodstream. And then your brain senses your oxygen levels. So as a protective mechanism, your brain will wake you up so that your muscle tone increases, so the muscles around your airway get better tone, open your airway, and there's more room for air. So your brain can wake you up multiple times an hour as a protective mechanism. So that's the partial upper airway obstruction. That's the hallmark of obstructive sleep apnea. So it causes repeated arousals from sleep. It fragments your sleep. After a partial airway obstruction, you have a decrease in oxygen and you have an increase in carbon dioxide. And as you're probably familiar, over decades, that can increase your risk for heart disease, stroke, diabetes, dementia. But in the short term, that can affect your day-to-day functioning in terms of learning and behavior and emotion. So this was a study that looked at the prevalence of obstructive sleep apnea in patients with epilepsy, and they frequently coexist. So in general, in all comers, so not patients with epilepsy, children with or without epilepsy, in general, everybody, 1% to 4% have obstructive sleep apnea. But in children with epilepsy, the percent that have obstructive sleep apnea increases to about 25%. But in patients with refractory epilepsy, that prevalence increases to about 33%. In patients with focal seizures, it's about 32%, and in patients with generalized seizures, it's about 28%. So obstructive sleep apnea is typically worse in stage REM. So REM is rapid eye movement sleep. It's one of the deep levels. It's when the stage in which you dream. So you are paralyzed during REM sleep, basically, so you can't act out your dreams. So you have zero muscle tone. So your airway is pretty narrow at baseline in REM sleep. So you're more likely to have even more narrowing of it with your partial obstructive events. So obstructive sleep apnea is worse than REM. So it frequently disrupts REM. So then you're going to have less percentage of your night in REM. Well, that's a problem in general, but it's really a problem in patients with epilepsy because REM is protective against seizures as opposed to non-REM sleep. So their sleep is broken up into REM and non-REM, and in REM, your brain waves are desynchronized, similar to wakefulness. Whereas in slow wave sleep, your brain, in non-REM sleep, your brain waves are more synchronized. So when things are more synchronized, it's easier for a seizure to develop and for those electrical potentials to be generated. So of the sleep stages, REM is protective against seizures. So you want to, protect your REM sleep if you have epilepsy. So that's an example of what we call a hypnogram. It's a visual representation of the sleep stages. So the top flat line is wakefulness. The red lines, that's REM. So it's normal to have more REM in the second half of the night. And the gold standard for evaluating for sleep-disordered breathing in children is with an in-lab PSG, or polysomnogram, which is a sleep study. And there are certain things, pieces of information that are obtained from a sleep study. Sleep efficiency, which is the percentage of the time in bed you're actually asleep. Sleep architecture, meaning is your brain going in and out of the different sleep stages in the normal proportions of the night? How much time did you sleep? Looking at kicking leg movements, looking at cortical arousals, looking at your heart rate, looking at your breathing rate, measuring your oxygen and carbon dioxide. That's done in real time all night. And then we look for obstructive events, meaning decreased airflow. And then we look at central events, meaning your brain doesn't tell your body to initiate a breath. So this is an example of, this isn't what a sleep study looks like. It looks similar to an EEG, but this is a data table summary of what a PSG looks like. And you can see on the left, there's the top red line is oxygen. The blue, quite squiggly variable line under it is heart rate. Underneath that is the hypnogram. So you can see this patient had look at the REM bars, the red, she had a nice amount of REM. And then there's calculated tables there. That's based on what the sleep technologist who is there overnight is scoring basically in real time. We, as the sleep medicine physicians, review everything in the morning and make sure we agree with the scoring. And you look at how many events per hour there's obstructive events. We look at how many events per hour of the central events. And then we look at oxygen, and in children, we like it to be above 90. So it's normal to drop your oxygen after an obstructive event, but typically it's only for a fraction of a second or two, and then you come right back up. So I wanted to briefly mention something called actigraphy, because this is relatively new. It hasn't been used for very long, probably within the past 5 years. This is like a Fitbit. It's a watch band that you wear on your wrist, and it's a motion detector and a light detector, and it tries to determine, based on that, are you awake or are you asleep? So this can be helpful, particularly in patients who are nonverbal or autistic, or wake up in the middle of the night and may not call out for their parent, so parents may not be aware, are they awake, are they asleep, are they just laying in bed for hours? But it is, if kids have sensory difficulties, it can be problematic because it is a wristband. But that is something that can be used to obtain a more objective measure of total sleep time. Are there prolonged nighttime awakenings? Are there early terminal awakenings, like our kids waking up every morning at 3 a.m.? So this is what it looks like after you download the data. So the pink is when it thinks you are asleep, and the black is when it thinks you are awake. So I indicated midnight and 6 a.m., so just imagine vertical lines down from that. you can see this 17-year-old basically, just from eyeballing it, she's falling asleep at midnight or later most nights. And then let's say you are diagnosed with obstructive sleep apnea. That's treated a little bit differently in children than it is in adults. So in adults, the first-line treatment is positive airway pressure, or CPAP, where you sleep with a mask attached to a machine, and regular air, not oxygen, room air, is pressurized, and it keeps your airway open. So in children, that is not first-line treatment. It's because their sleep apnea is typically caused from a physical obstruction in the upper airway, most commonly enlarged tonsils and enlarged adenoids. So adenotonsillectomy is first-line treatment for pediatric sleep apnea. That does not work. It does not resolve the sleep apnea 100% for every patient. About 80%, it will resolve it completely. So depending on the severity of the residual sleep apnea, or if it's only mild to begin with, there's some other treatments that can be used, including CPAP, but also things such as Flonase nasal spray, which is an intranasal steroid which decreases inflammation and can shrink some of the inflamed tissue and give you kind of more room for air to flow. And then if people are overweight or obese, weight management will also help, because typically you have extra soft tissue in your neck, and then when you fall asleep, that's kind of contributing to the pressure on the airway. So this was a meta-analysis where they looked at 14 studies to try to see how effective is tonsils and adenoids out in treating pediatric sleep apnea. And it does appear effective. So there was a reduction of about 13 obstructive events per hour after surgery compared with at baseline. And the success rate at what they call normalizing the PSG, meaning resolution of the sleep apnea, was about 83%. But 83 isn't 100, so there are some patients where it does not work completely. Now, unfortunately, in the odds of it not working completely increase if you have Down syndrome or another, like Pierre-Robin sequence, some type of craniofacial abnormality where the structure of your facial bones or your jaw, or in Down syndrome, large tongue, mid-face hypoplasia, those types of anatomic structures that you're not changing by taking the tonsils and adenoids out, you're more likely to have residual sleep apnea after surgery. But that's also the same patient population that might have a really hard time tolerating CPAP. So this is what a typical CPAP mask looks like. This is a nasal mask. So this just covers your nose. So this, I'll also just throw this in because if your child is diagnosed with sleep apnea, the DME companies frequently recommend a full face mask. That's something that covers your nose and mouth. That's fine for adults. That is not fine for children with seizures, anyone with seizures. Because if you have seizures, you want to make sure your mouth is not covered up by a mask, because if you have extra salivation, if you vomit, you want your mouth to be open and not covered with a mask with pressure so that that can come out and not down. So what we do in children, we don't try to start them wearing a mask overnight at first. That sometimes works in adults, but it's much better for everyone, in my opinion, to start things slowly and gradually. So we actually have a whole process of mask desensitization where we would have the child start wearing the mask just for a minute or two during the day while they're awake, not hooked up to the pressure, doing something distracting or something they enjoy doing, just to get the feel of it on their face. And then we increase that by like 5 minutes or so a day until they can wear it for 30 minutes. And then when they can tolerate that during the day, we do the same thing at bedtime. So when you're laying in bed trying to fall asleep, there's no distractions. So it's harder to tolerate at that time than it is during the day. So we repeat that process at bedtime until they can fall asleep wearing the mask, and then only then would you try it with pressure. So it's basically, it's a marathon, not a sprint. Like, it's much better to have them not hate it when they first put it on or get scared by it, or sometimes if they get a wave of pressure, just once is enough to never want to try that again. So it's much better to go super slow. Okay, moving on to pediatric insomnia. So again, there are no FDA-approved medications. And behavioral therapy is always recommended first line, or sleep hygiene measures, basically meaning look at the whole situation. Are there factors that can be improved upon that may make it easier for their brain to initiate sleep and stay asleep? So medications can be used in combination with the behavioral changes, but especially in this patient population, everyone is on a seizure medication. There are side effects to every medication, and there are drug interactions that you should be aware of, because sometimes certain medicines can make sleep disorders worse or vice versa. So what we typically recommend just for basic sleep hygiene is consistent bedtimes and rise times, meaning if your brain is initiating sleep and waking up from sleep about the same time every day, and about the same time means varying by no more than 2 hours, it will learn to initiate sleep and wake up from sleep just out of habit. It'll be easier to fall asleep and wake up at a certain time if that is consistent. Also, your brain makes an association with sleep onset. So meaning, if you do the same 3 activities every single night before bed, like wash your face, brush your teeth, be read a story, get into bed, quick 10 minutes, doesn't have to be drawn out, your brain will start to associate those activities with sleep initiation. So it can make you fall asleep easier after you do those activities. So in terms of electronic screens, pretty much anything with a screen will emit blue and white wavelength light. And those wavelengths of light, particularly blue, which are shorter wavelengths, like red, if you think of the colors of the rainbow, the beginning of the rainbow, red, orange, yellow, those are long wavelength, but the end of the rainbow, green, blue, those are short wavelength. So short wavelength shuts off your natural melatonin secretion. So your pineal gland in your brain naturally secretes your own natural melatonin starting 3 hours before you normally fall asleep. So that's another reason to have a consistent bedtime, because if your brain is falling asleep more consistently at a particular time, your natural melatonin secretion is going to be more consistent at a particular time. And melatonin helps you fall asleep and stay asleep. It helps you fall asleep better than it helps you stay asleep. But if you use something with a screen, TV, iPad, anything, even like those bright lights or the fluorescent LED lights, that's enough to shut off your natural melatonin secretion. So in an ideal world, you would avoid that 3 hours before bedtime, but in reality, we aim for an hour. And then also, you want your brain to associate the bed with sleep. So you don't want to be doing mentally activating activities in bed. So I completely respect the eating waffles with peanut butter in bed because that's the current habit. But in general, like some people will, work on schoolwork, watch TV, watch movies, pretty much use your bed as the living room couch. And we recommend against that because we want to keep the bed separate just for sleep. So the American Academy of Sleep Medicine has some recommendations for the recommended amount of sleep time in a 24-hour period. So this includes naps. So it's nighttime sleep plus naps. So, school age, 6 to 12-year-olds is 9 to 12 hours, and then 13 and up is basically the same as adult, 8 to 10 hours. And then the younger kids, I found it's harder to remember, but 4 months to 12 months, anywhere from 12 to 16 hours, and then 1 to 2-year-olds, 11 to 14 hours, and 3 to 5-year-olds, 10 to 13 hours. Moving on to some of the medications that are typically used for insomnia. So melatonin, as we just mentioned, is a natural hormone that your pineal gland secretes. It's also over-the-counter synthetic hormone. And melatonin works 2 different ways depending on the timing you give it and the dose. So in this situation for insomnia, you want to take advantage of the hypnotic property, meaning like a sedative, meaning it makes you drowsy. So that the hypnotic property of melatonin works if the dose is 1 milligram or higher, and if you take it 30 to 60 minutes before desired sleep onset. There's another way melatonin works, and that's called the chronobiotic property, and that basically means it shifts the chunk of time your brain is usually sleeping, either earlier or later on the 24-hour time clock. So that can help with, like, that teenager that the actigraphy was done on. She was falling asleep at like 2, 3 a.m. In an ideal world, when you have to get up for school, you would want her to be falling asleep, well before midnight. So you could use melatonin in a dose of less than 1 milligram, given 6 hours before you want to be falling asleep. That won't make you drowsy, but that should make you drowsy at whatever time you're aiming for. So melatonin is typically well tolerated. It can have side effects. The one I hear most from patients is nightmares. So keep that in mind. If patients are not able to express in words, that they're having a nightmare, but you're noticing more frequent nocturnal awakenings or restlessness, that very well could be increased nightmares from melatonin. Also, increase in headaches. Some patients with migraine will report increased headaches, and then a hangover effect. So I hear that pretty commonly from patients as well, where they've tried, a certain amount, 1 milligram, but then when they went up to 3, they were, they noticed it was very hard to wake up in the morning because they had that hangover effect. So melatonin, there's, as often as people use it, there's not a whole lot of data, safety data, or data in general on effectiveness. But what is out there, there's actually more evidence for it being beneficial in children with special needs than children that are neurotypical. So the immediate release formulation, the peak effect is within 1 hour, which is why we would recommend taking it 30 to 60 minutes before bedtime. And there are some guidelines from different societies for maximum dosing. So less than 40 kilograms, which is about 90 pounds, they say 3 milligrams. More than that, they say 5 milligrams. But other societies or guidelines have said that children with special needs sometimes respond to higher doses, going up to 9 to 10. It comes in a controlled release formulation too, which theoretically can be more effective to help with sleep maintenance, meaning staying asleep through the night. It has a half-life that's longer than the immediate release. But the problem with that is it's hard to find, and you're not supposed to cut those pills in half if they're extended release, so that can be problematic if you're trying to reach a particular dose. And theoretically, melatonin can suppress the hypothalamic gonadal axis, meaning it can affect puberty, hormones, and it can affect your immune system. It can have some immunomodulating properties, so they recommend being careful if kids are on immunosuppressants or with underlying immune disorders. So this was a study where they looked at they looked at melatonin in children with epilepsy, not Dravet syndrome, but epilepsy in general. And they used the 9 milligram sustained release compared to placebo. And they did an overnight PSG. And they found that melatonin did decrease sleep latency, meaning how long it takes you to fall asleep initially, by about 11 minutes. And it decreased wake after sleep onset time, meaning how much of the time at night you're awake after you fell asleep for the first time, by about 22 minutes, and it didn't worsen seizure frequency. It increased slow wave sleep duration, which is a stage of sleep, but it decreased REM, which theoretically would not necessarily be helpful, and one patient with migraine had worse migraines. So this is a study where they looked specifically in patients with Dravet syndrome with melatonin. And the mean age of the patients with Dravet syndrome was 12 years, and they used 6 milligrams of melatonin, and they gave it 30 minutes before bedtime. And they did actigraphy, which was the wristband. And there was no statistically significant difference in total sleep time or wake after sleep onset time between melatonin and placebo. Yet, despite that, 8 caregivers reported significant clinical improvement on melatonin. So moving on to clonidine. So this is a medication that's frequently used for ADHD, and the onset of action is within 1 hour, and peak effect is within 2 to 4 hours. So this is commonly used for sleep, particularly in children with ADHD or children that have a difficult time like settling their brain prior to sleep. It can decrease REM, and it can decrease slow wave. And whenever you decrease REM, then when you stop the medicine or skip it for a night, you'll get a rebound of that stage. So you can get vivid dreams or nightmares because of that rebound. And it can affect blood pressure and heart rate, and it has a pretty narrow therapeutic index. So that means there's more potential for side effects. Guanfacine is in the same class as clonidine. That is also used frequently for ADHD and for tics. It has less sedation and less cardiovascular side effects than clonidine. There are very, very few studies on the effectiveness of this or safety long-term in children. One study in patients with ADHD showed it decreased total sleep time. And I found this study. So basically, they looked at children who had a diagnosis of ADHD, and they were taking guanfacine for that reason. But they asked about, quote, sleep problems, which was basically kind of broad. And then they actually looked at the dosing of guanfacine starting at 1 milligram and then increasing by 1 milligram once a week to a max of 4. But if you had effect, you stayed on whatever dose you were on where you had benefit in terms of your ADHD. And they actually stopped the study early because they were noticing, doing their preliminary statistical analysis, that the group that was on guanfacine, they actually had less total sleep time and increased wake after sleep onset time, which basically comes out to the same thing. So they stopped it early for that reason. Trazodone is also sometimes used for sleep, more commonly in the adult population. It's a very sedating, atypical antidepressant. And you're basically taking advantage of the side effect of sedation and making you sleepy to try to induce sleep. So this suppresses REM, which I don't know is the best idea in patients with epilepsy. And just like all the other medications, there's very, very few studies on the effectiveness with insomnia. In terms of take-home points, sleep disorders, especially sleep-disordered breathing, are quite common in patients with refractory epilepsy. If you note symptoms of sleep-disordered breathing, it's worth being evaluated for it because it can be diagnosed and treated. Insomnia is a very common complaint in patients with refractory epilepsy, and of the medications that are commonly used in this age group, melatonin has the most evidence base. And these are my references. And I'm happy to take any questions.
Hello. Thank you
Hi.
for sharing all this. I do have a question. So we occasionally use melatonin for my 2-year-old to help her fall asleep, but it's the staying asleep that all of the time.
Mm-hmm.
So do you have any recommendations with that of how to help in the middle of the night when she is just wired and ready to play?
So 2 options that may help. One is redosing. So either give a half dose at bedtime and then save a half dose for a middle of the night awakening, or the extended release formulation.
Thanks.
Sure.
Could you talk a little bit about?
Sorry, I can't see a
I know
thing.
you can't see.
Okay.
Can you talk a little bit about bedwetting and what we know or do not know about when that happens and sleep cycles?
So the The real answer is nobody really knows. My suspicion is I think it happens out of slow wave sleep, because in non-REM sleep, slow wave is the deepest level. Your brain waves are like the most slowed. And that's the stage where, like, if somebody tries to wake you up out of it, like you feel like you got hit by a bus, like you can't really think, that's slow wave. So it makes sense to me that in that stage sleep, you're not going to be able to sense a full bladder. Whereas like in REM sleep, your brain waves are pretty close to the frequency that they are in wakefulness. So when you wake up out of REM, like you feel fine, like you feel alert. So my guess is slow wave. I don't know that that's been studied.
Good afternoon. Could you just comment whether melatonin is appropriate to use at nap time as opposed to just bedtime? Because I've seen that done.
My personal opinion is no, only because it's going to last much longer than the nap.
Okay, thank you.
It's also going to mess up the whole circadian rhythm.
Hi. Are there any concerns with long-term use of using melatonin?
So that's an evolving field. There was actually just a paper published. I know Dr. Kodagal and colleagues, I actually have not read that yet. That is on the to-do list, but it just came out last month where they looked at that. But there's been a whole series of studies and like recommendations from different societies that there's no long-term safety data in melatonin. It has not been studied. So you want to use the lowest dose that's effective for the least amount of time. Thank you.
So you mentioned in your slides that REM sleep protects from seizures, but for kiddos like my daughter who are nocturnal with their seizures, how do you correlate? Like sometimes we feel like we don't want her to go too deep into sleep because that's when the seizure will kick over. But how do you kind of correlate all of that with REM?
So I suspect, so when you go to sleep at night, like you have most of your REM in the second half of the night and most of it 3 hours before you naturally wake up. But during the night, your brain is constantly, like every 90 to 120 minutes, going up and down, in and out of the different sleep stages. So just because it's later in the night, like doesn't necessarily mean you're in a deeper stage. Like you can start out like falling asleep into REM. I mean, babies do that. Like 50% of the time is in REM when they fall asleep. And then as you age, it's the timing and the percentage of REM changes. But in general, like at any time of the night, you could be in any stage sleep. So if it's hard to judge based on like what time they went to bed, what stage of their sleep they're going to be in. So I don't know. I think it's hard to figure out, like it would be hard to guess what stage are they coming out of just based on what time of the night it is. Some things that can help you try to figure out if they're in REM, in slow wave sleep, which is non-REM, your breathing is real regular. Like your respiratory rate is very regular. But then in REM, it's not. It's irregular, and you have little like 3-second pauses. So that can sometimes be a clue of what state you're in.
Hi, do you know if daytime napping affects nighttime wakefulness?
Yes. Yeah, and yes. So daytime napping, especially after the age where you typically stop napping, which is about 5 or 6 years, daytime napping is going to make it harder for your brain to initiate sleep at a typical bedtime because it decreases your sleep drive. So meaning like your brain's natural ability to feel tired and drowsy at a certain time. So particularly naps that are great, like longer than a half an hour in duration, because longer than a half hour naps, you're guaranteed to go into slow wave sleep, and you're probably going into REM. You may or may not be going into REM. Those two states, slow wave and REM, are very restorative. So when you get them or go into them as part of your nighttime sleep architecture, they're restorative. When you go into them as part of a nap during the day, you don't get the same benefit. So even though you sleep, say, however many hours at night, the quality of that sleep in terms of how restorative it is going to differ. And taking daytime naps, particularly prolonged ones, like later in the afternoon, can definitely negatively impact the quality of your nighttime sleep.